Hi, thank you, Morelos. Hi, buon noche, notte. My bad Brazilian, bad Portuguese. A huge pleasure to be here. Thank you very much indeed for the invitation. It's always lovely to come to Brazil. It's a wonderful country, lovely people, and obviously a bit of sport happening in the country at the same time. So well done, Brazil, on your first gold medal. Yeah, we won one too, so the British should have got one too. Okay, what I'll do is I'll talk for 20, 25 minutes, and then there's, I think Dr. Murillo will give you a talk about what's happening in Brazil, and then a group discussion and lots of questions. As you heard, there's changes, a bit of controversy, but that's good because controversy makes people think, discuss and form opinion. So I'm very happy that there is the opportunity to think and discuss. So we had, once upon a time, Sepsis 1 in 1991. And then there was Sepsis 2 in 2001. And now we have the third version, Sepsis 3. And as I said, great pleasure. We were 4 years ago in London. And now in Rio at this precise moment in time. Okay, Sepsis 3. Hopefully you'll have read the paper. This came out in February in JAMA, and they very kindly also published 2 companion papers which basically gave the data that underpinned the recommendations that we've come up with. So, again, please, if you haven't read the papers, please do read them. It's amazing when you look on the internet and see people saying things that aren't actually in the paper. So, if you read the paper, please, you'll see, hopefully, what we mean and the rationale. And I'll try and talk a bit about that now. And it's out there. I downloaded this morning. 1.25 million, 1.25 million views. So the paper's out there, people are looking at it, hopefully discussing it. So why are we interested in sepsis? Well, it's an interesting condition, isn't it? It comes in all sorts of shapes and sizes. We see a patient, we have the sense that they have sepsis, they smell of sepsis, or that we touch them and they feel septic, or they look septic. So they have that sense about them, but it's often quite difficult to actually say definitively this patient has an infection and they're septic. We don't have a magic blood test yet or any other magic diagnostic. And you'll see lots of data, epidemiology, where there's this epidemic of sepsis cases. I'll talk about that later on. And clearly, I think it is a disease, a syndrome, a condition with a high incidence and a high mortality. But what's the true incidence? We'll talk about that later. And clearly, we want to get those patients who are on the edge, we want to try and hopefully capture them and pull them back before they fall off. So again, early identification, good, prompt, adequate treatment are clearly important. But it's important to stand back and look at the big picture. I think we're often too deeply involved, so I think it's good to stand back and reevaluate what we're doing. And I think importantly that we all talk the same language. Again, I'll show data to show that we don't talk the same language, and sepsis means different things to different people. And there's a big, big, big mess as a result in the literature. So we've had some people who don't want change. They say, why bother changing? It's disruptive. We've had SIRS and sepsis and severe sepsis and septic shock for the last 25 years. We're familiar with them. And if we have to start again with new definitions, we have to spend a lot of time and effort re-educating doctors, nurses, the public maybe, recoding. Do we have something better to replace it with? So hopefully I'll argue we do. But these are the arguments against change. So hopefully I'll gently destroy them, and we'll talk about why we think there is a need for change. I think if you read the literature, I'm sure you're aware of what goes on. It's not only confusing, but very confused. So it's a bit of a mess. The science has moved on in the last 15 years. The epidemiology is a complete mess. Sepsis means different things to different people. So when you'll hear later on about Brazilian data, and it will be different from UK data, American data, Australian data, because of the way we describe our patients. We don't describe them in the same way. When we talk about shock, do we mean the same thing? The answer is no. When we talk about organ dysfunction, different views. And we have this problem where we have infection and we have sepsis, and there's often this overlap when many septic patients or many infected patients are called septic. This is a lovely example. This came out in 2011. It was looking at this, there's this very large database of a representative United States hospital population. And they reported trends of severe sepsis from 2000 to 2007. And as you can see, the cases of severe sepsis were going up and up and up. But the good news is the mortality was dropping from 40% to about 27%. And the authors concluded an increasing number of admissions for severe sepsis combined with a declining mortality rate means more individuals are surviving to hospital discharge. But it looks good. Look at the survival improving. It's not so good, though, if you actually put the numbers in there. So let's look at the numbers. We have an increase in cases from 300,000 in the year 2000 to 781,000 in a mere 7 years. It's an epidemic of sepsis. And the mortality, if you multiply that by the proportion of patients dying, has gone up from 118,000 to 213,000. So the percentage has dropped, but the absolute number of patients dying has gone up 80%. So we're now having not more individuals, whoopsie daisy, sorry, I'll go back. We're now having not more individuals surviving, we're actually having more dying, according to these data. It's crazy, isn't it? Is the 300,000 because patients were underreported? Or is the 780,000 because patients are now being over-reported? In America, there's a financial incentive to call someone septic rather than pneumonia. It's the same patient, but you get a lot more money if they're septic. So it's a mess. And the same could be said, like quality improvement programs, whatever. We don't know the true denominator, how that's changed over time. So it's hard to say absolutely what the real impact is on mortality. According to these data, the proportions have gone down. The proportions have gone down, but the numbers have doubled or nearly doubled. Okay, sorry about this. Okay. So this is the old paradigm. Infection, 2 or more of the old of 4 SIRS criteria makes you septic. Organ dysfunction makes you severe sepsis. And if you have a cardiovascular collapse, whatever that means, not responding to fluid, you have septic shock. But we've learned that sepsis isn't just about inflammation, that there's too much overlap between infection and sepsis. In 2016, does SIRS really fit within the construct of sepsis? What do we mean by organ dysfunction? What do we mean by shock? Again, all of these important questions that we can now challenge the existing definitions to try and clarify them. Okay, let's briefly touch on these things. So sepsis isn't just about inflammation. So you see in the media, this is somebody who was fighting for his life against brain-eating amoeba. And this is a flesh-eating streptococcus, flesh-eating bug. But that's not actually true for the vast majority of cases of sepsis. They don't just chew their way through the tissue, the organisms. Rather, the organism triggers a host response. And most of the time, it's a regulated host response and the patient recovers. But sometimes that host response, and it might be actually a relatively minor infection, causes a dysregulated host response that can lead on to organ dysfunction and maybe death. So it's not the bug to blame, the bug is the trigger, but different people will react in different ways to an identical insult. So in some people, you get this dysregulated, exaggerated response, which leads to organ failure and in many cases death. So it's not just about inflammation. At the same time, many other things are going on. Many other systems are activated, upregulated, or even downregulated. And it's a great big mélange, a minestrone. So just thinking about it in terms of inflammation is, I think, a little bit too simplistic. So we need now to incorporate our bigger picture into our new understanding of what we mean by sepsis. And to give you a few examples, there was a New England Journal paper looking at patients admitted with organ failure related to infection to Australasian intensive care units. 1 in 8 didn't have 2 or more SIRS criteria. So by the old definition, those patients needing ICU admission with infection-related organ failure did not have sepsis. On the other hand, you may have a patient with a cold. They have a temperature, they have a high heart rate, infection and 2 or more SIRS criteria. They're septic. No, they're not. They've got a cold. No. They're septic. Again, probably not. Likewise, when we talk about organ dysfunction shock, it means different things to different people. This is just an example of looking at the way different papers, different publications have looked at shock. A whole variety of different criteria, some being a lot softer than others. And as a result, when you look just at observational studies, you can get up to a 10-fold variation in incidence and a 4-fold variation in mortality. If you make less sick patients shocked, you'll have more of them and the mortality will be lower. If you have fewer patients who are sicker, you'll have a much higher mortality. We're not talking the same language. Australia have about a 9-time higher incidence of septic shock than Italy and a 4-fold lower mortality. Something's wrong somewhere in the translation. Not your translation. So we had the task force. So the Society of Critical Care Medicine and the European Society put together a task force, and I had the honour of co-chairing it with Cliff Deutschmann, who was then from Philadelphia. He's now in New York. And what we wanted to do was combine our latest understanding of the science with big data, because now there's these very large electronic health records where we can actually ask questions and get, hopefully, some useful answers. So we put together a group, in total 19 patients. There were 16 and 3 were co-opted who did a lot of the hard work with the data analysis, who had expertise in epidemiology, in clinical trials, and in mechanisms. So we had a lot of people who could talk about organ dysfunction at a different organ level or immune function, metabolic function or whatever. And we had a number of questions. Can we improve upon the existing definitions and the clinical criteria from 2001? Can we offer something to aid the clinician, the researcher, the epidemiologist, the hospital coder? It wasn't our remit to go into patient management, that surviving sepsis campaign, etc. Our job was just to look at the definitions and the clinical criteria that describe them. There is no right answer. If there was, you wouldn't be here now, I wouldn't be here now. And we wrote that in the paper on the limitations. Our first limitation was we still don't fully understand sepsis, and there's no simple, easy test that applies across every septic patient. So we are making assumptions. It's not perfect. We hope it's a bit better than before, but it's still not perfect. There will be better diagnostics in the next 5 years, 10 years, 20 years, much better diagnostics, but we're not there yet. So we wanted these new definitions based on the science, supported by the data, that could be easily and conveniently applied by the clinician at the bedside. And we use big data, as I said earlier, mainly from large US electronic healthcare record data of hospital populations, not ICUs, but hospital populations. So we had over 5 million patient encounters, of whom 850,000 were cultured and then treated for suspected infection. We don't know whether they all had infection, but the clinician was worried enough to take the cultures and start giving them antibiotics. 850,000. The majority, 90%, were outside the ICU. So we were very conscious when we're talking about sepsis, it's not an intensive care problem as such, but it's for the community, the emergency department, and the ward. We use the Pittsburgh database as the discovery database. So 12 hospitals in the West Pennsylvania region, some small, some large university hospitals. 1.3 million encounters, of whom 11%, nearly 150,000, were cultured and treated with antibiotics. 89% outside the ICU. Of these 150,000, only 4% died. So it's not large. It'd be fascinating to know what the number is in Brazil. But it's relatively small. And we don't know if they died of the infection or another problem that brought them into hospital. End-stage cancer, end-stage lung disease, whatever. Of these patients who were being treated for infection, how many truly had infection? Again, we don't know. So if you do the mathematics, only 1 in 200 of the entire population died of or with suspected infection. So sepsis is clearly important. It needs, as I mentioned earlier, to be promptly identified, quickly treated. But we do need to put it into perspective. The vast majority of patients with infection do not become septic, develop organ dysfunction, do not go on to die. A proportion certainly do get organ dysfunction, so we want to try and identify these patients really early and jump on them to prevent them from deteriorating and dying. So with the new definitions, we wanted to try and simplify it. Rather than infection, sepsis, severe sepsis, septic shock, we wanted to say you have infection, and when it's bad, you have organ dysfunction, you have sepsis. And septic shock forms a particularly bad subset of this population with sepsis. So we hope this is a much simpler way of describing it. We'd avoid the overlap between infection and sepsis, between sepsis and severe sepsis. What do I mean by definition? Well, a definition, if you go to the dictionary, is what something is, the essence of something. So we had lots of discussion, and we came out with this definition. Sepsis is defined as life-threatening organ dysfunction due to a dysregulated host response to infection. So we wanted to emphasize life-threatening. They're more likely to die from this than from a standard infection. Organ dysfunction. You don't die of the infection without getting organ dysfunction. So again, we're emphasizing the organ dysfunction, the host response. And it's not just inflammation. So we've got to look with our treatments beyond quenching the flames of inflammation towards having a much broader approach to treating these patients. So that's the definition. How do we characterize it clinically? How at the bedside can we recognize it? So again, a lot of discussion, and we came up with using the SOFA score, a change of SOFA score of 2 or more related to the infection. So if the patient is known to have chronic morbidity, giving them SOFA points, you want to change over and above their baseline level. If they're otherwise healthy, you can assume the score is nil as a baseline and you're looking for a change. So that is a formal way of defining that that patient has got new organ dysfunction related to an infection and they qualify as being septic. That's a reminder of the SOFA score. Again, the beauty of the SOFA score, it's been around a long time. The higher the SOFA score, the more likely the patient is to die. And it's done on routinely collected data, so you don't have to do anything over and above the routine things you would normally do. Glasgow Coma score, blood gases, blood pressure, the creatinine or the urine output, platelets, bilirubin. These are things that are routinely measured, so we're not asking for a fancy test. And when we looked at the data, these big databases I was talking about, if you had infection with a SOFA score of 2 or above, that gave the patient a more than 10% chance of dying. So in other words, it is a life-threatening infection, as 1 in 10 of these patients will end up dying. So we're not saying, oh, you have to stop treating the patient, do the SOFA score. Absolutely not. You treat the patient in front of you. If you're worried about their breathing, their urine output, their blood pressure, you're treating them. The SOFA score, you're doing the blood test to look at their organ function. That can be done as a post hoc test to help the epidemiology, the research, the hospital coding. Often we don't know that the patient has an infection until the disease, the condition evolves in that patient. It might turn out to be something else. Pancreatitis, for example. So we think it's infection, but we later change our diagnosis. And certainly in our ICU database where I work in London, many of these computerized systems can calculate SOFA automatically. Again, taking the human work out of it because the machine does it for you. Moving on to septic shock. Again, the definition we came up with was we wanted it to reflect a group of septic patients where they have not just a circulatory problem, but a metabolic cellular abnormality, which is severe enough to substantially increase their risk of dying. So we wanted that combination. We felt that septic shock, from a pathophysiological point of view, wasn't just a low blood pressure. It had to reflect that the cells were not happy as well. And the risk of dying had to be much higher than a normal septic patient. So we characterized it, again, by looking at databases as having, after fluid resuscitation, a lactate above 2 and a mean arterial pressure 65 or above. So after fluid, they still had a high lactate, they still had a low blood pressure, needing pressors to elevate it. If the patient qualifies as both of those, they have septic shock. And we've had some people saying, well, why didn't you have either or? Why did you need lactate and hypotension? Again, this concept in the definition of having a group with a much higher mortality. So we went here to the Surviving Sepsis Campaign database. 28,000 patients who, after fluid resuscitation, had more than 1 organ dysfunction. And their hospital mortality was much higher in patients who had both hypotension and a lactate above 2 compared to those with a lactate alone, or compared to those with just a low blood pressure alone but a normal lactate. And impressively, even if you had a normal lactate and the normal blood pressure but you still had organ dysfunction, the mortality was equivalent. So it was only that group who had both of them had a much higher chance of dying, which separated them from the other patients. So that's why we picked having both. It will reduce the numbers of patients having septic shock, but it will give a better indication of why they died. If you look at the 3 early goal-directed trials, therapy trials, PROMISE, PROCESS, ARISE, I was involved with PROMISE in the UK, only about 15% of patients fulfilled this criteria. Everyone talks about, low mortality, low mortality. Well, the reason there was a low mortality is because mainly these patients were the ones being enrolled. So it was predictable because they were a less sick population. Final few minutes on QuickSOFA. Can we use big data to offer a risk stratification tool that would be easy to use to identify patients at risk of having sepsis? So Chris Seymour in Pittsburgh, who did all the hard work, he looked at 24 variables that are routinely collected in ward patients or emergency room patients and found 3 were the best predictors of a high chance of doing badly. A low systolic blood pressure, an altered mentation, any change in Glasgow Coma score, or tachypnea 22 or above. So the low blood pressure reflects this cardiovascular dysfunction maybe, the change in mentation, neurological dysfunction maybe, the tachypnea, respiratory and or metabolic dysfunction. And he found that the more SOFA points these infected patients had at the time of diagnosis, the more likely they were to die. So you can see here, if you had 2 or more, that put the patient in a much higher risk category. We in the UK, I know you don't in Brazil have a national system, but we in the UK do have a national system called NEWS, National Early Warning Score. So it's used in the wards and it's now going to be used in the emergency departments. And so the nurse basically scores the patient and they get more points for more abnormalities. And there are 7 different parameters, things that are routinely measured. And very conveniently, the QSOFA criteria, respiratory rate, blood pressure, level of consciousness, came up really nicely within this system. And what happens in the UK, depending on the hospital, but the critical care outreach team get called if the score is 4 or in some hospitals 5. So if you have 2 of the SOFA criteria, you have a minimum of 4 before looking at the 4 things that aren't recorded by QSOFA. So in the UK, it fits very, very nicely into this existing system, and QSOFA will be incorporated within it. So we're not going to change what we do, but we'll be, because we are recording QSOFA as well. So final few comments. Is there a place for SIRS? In part, yes. The components, the white count, the temperature, help us identify whether the patient may have an infection, which may or may not prompt antibiotic treatment. You don't need to give antibiotics to every patient with infection. A lot of the time, patients get well without antibiotics. Certainly, some patients do need antibiotics. The advantage of QSOFA over SIRS, you can do it in 30 seconds, 1 minute at the bedside. You don't need to take the blood test to measure the white count, to measure the blood gases. So you don't need SIRS to diagnose sepsis. It can be helpful towards diagnosing infection. What about lactate? If you find lactate useful for your management of the patient, carry on doing so. we were focusing just on the definitions, not on the treatment. So you don't need lactate to diagnose sepsis, but you do need it to diagnose septic shock because it's a marker. It's not perfect, but it's a marker of cellular metabolic abnormalities, which goes into that definition of septic shock. And I won't go into it now, but when you look at the evidence base about the wonders of lactate as a prognosticator, it's a lot weaker than the true believers claim. Q-SOFA is not a diagnostic for sepsis. It's a prompt, a risk stratification tool. The patient may have sepsis. You need to do the blood test to look at their organ dysfunction. It might help the nurse alert the doctor, I'm worried about this patient. Perhaps more intervention, more monitoring, step up to intensive care. But again, it's a way of making the nurse, the bedside doctor think this patient with infection is getting worse. But don't wait until they get to 2 before you start treating them. If you're worried, if they need antibiotics for their infection, start treating them early. If they need fluid for their oliguria, or oxygen for their hypoxemia. Sorry, not hyperemia, that's a typo. Start treating them. So don't wait until they're ill. And we put that in the paper, in the algorithm. If they do have a Q-SOFA of 2 or above, they're in a high-risk group. You need to do the blood tests and take them seriously. If you're still worried, they don't have 2 or more Q-SOFA, still take them seriously, do the blood tests, think about escalating, monitoring, treatment, intensive care, referral. For pediatrics, the definitions still hold true, but clearly the physiology is very different at children at different ages, and there are pediatric definitions or initiatives underway at the moment. What about countries that can't do blood tests, can't measure lactate? Perhaps Q-SOFA may be a good surrogate. We don't know. It needs to be prospectively validated. For septic shock, if you can't measure lactate, perhaps use a marker of poor perfusion, like capillary refill. Again, needs to be prospectively validated. But point-of-care testing is increasingly available, increasingly cheap, even in very remote locations. So what next? The future? The work was done mainly on US databases. Does the American patient reflect the Brazilian, the British, the Australian patient? We don't know. We need to prospectively look at these things. Q-SOFA. We need to come up with perhaps a better organ dysfunction score, more up to date than SOFA. And we need lots of studies. This will hopefully encourage the work that we're talking the same language and we can compare Brazil to the UK, to the US, etc. And you can see how you're doing within different hospitals in Brazil at now and over time. So hopefully we're offering more objective data, more reproducible data and better generalizability. And hopefully Q-SOFA will give a useful bedside prompt. It needs prospective validation. It's not the final word. More research will give us more knowledge, and there will be a sepsis 4 after sepsis 3. But I certainly, for one, do hope we've made some progress. Thank you for listening.